Good evening, Raman.
Madam. Good evening.
Hello, sir. Good evening, sir.
Thank you, madam. Thank you for joining.
Yes, sir. Thank you, sir.
Shanti madam, good evening. Dr. Sudhakar.
Hello, sir. How are you, sir?
See, she is very busy. Fine. Because her faculty is speaking, she is joined.
No, sir. Okay, I have attended so many webinars in these 8 months.
Sir, shall we start, sir? President, sir.
Hello, sir. Suresh, sir. Good evening, sir.
I wished you first. I thought you responded to me.
Sorry, sir. I missed you, sir.
To me.
My teacher.
Yes, sir.
Yes, sir. So, good evening to all. So, it's my pleasure to welcome the President of Indian Psychiatric Society, Southzone, Dr. K. Ramakrishnan, sir. The General Secretary of IPS Southzone, Dr. G. Suresh Kumar. The Vice President of IPS Southzone, Dr. Ramanan Irad. The Honorary Treasurer of IPS Southzone, Dr. K. Gangaram. The Honorary Editor of IPS Southzone, Dr. Shagul Amin. And the rest of the CME committee of Dr. Lokeshwar Reddy, Dr. Sai Krishna, and other members of the CME committees, and all the rest of the EC members of the IPS Southzone, I welcome wholeheartedly for today's webinar of the WISER program, of the second program of the IPS Southzone December month 2020 webinar. I am also overwhelmed to welcome today's chairperson of the WISER program, Dr. T.P. Sudhakar, who is a senior psychiatrist, professor of Apollo Medical College, Chittoor district. Dr. T.P. Sudhakar is a past president of IPS Southzone 2017-18, and he is a person of a versatile teacher with an experience of more than 35 years in the field of psychiatry and has guided more than 30 dissertations. He is also a member in the various psychiatric association of zonal, national, and international and psychiatric organizations. And I welcome you, sir, Dr. T.P. Sudhakar, sir. I am extremely happy to welcome today's speaker, Dr. M. Suresh Kumar, sir, a senior psychiatrist and the director of SciMed Hospital, Chennai. I welcome you, sir, Dr. Suresh Kumar, sir. I also welcome the young enthusiastic speaker of today's WISER program, Dr. Raman, who is a professor of psychiatry, Savita Medical College for the WISER program. Dr. Raman, I welcome you. I also extend my welcome to all the delegates of today's webinar lecture. The participants' e-certificate will be given for those who have registered for the IPS Southzone CME December 2020 webinar. So with this short welcome, I just hand over the mic to the president of Southzone to give his presidential remarks. Dr. Ramakrishnan, sir.
Thank you, Dr. Aravind, our young dynamic CME chairperson. Thank you for giving this opportunity. And I am very glad we have taken up this WISER program very fast. Last month itself, as soon as the office assumed office, we started the program with the Professor Gangadhar's inaugural speech, and now is the second one. And it is heartening, in spite of 4 meetings are at present going on, but still 420 people have joined. So that itself is a credit goes to the speakers, not to us, but to the speakers, how valuable the speakers are. That goes to this. And the very purpose of our WISER program is to encourage young psychiatrists to come up and showcase their talent. So in that way, this program, we have got a very senior psychiatrist, Dr. M. Suresh Kumar. We need not tell so many things. You have heard about hypnotism, you have heard about mesmerism. Have you heard anyone talking and mesmerizing you? That is Dr. Suresh Kumar. This I have been hearing from 1992. For the past 28 years, our hearing his songs in music through his lecture. That's what I would honestly say. It is not an overwhelming one. If you say anything latest, he is updated. He is actually an artificial intelligence. You can go to his to our IPS Tamil Nadu website to YouTube lecture. What he gave in the Pandi Tansaikon about artificial intelligence and VR. It is again a mesmerizing one. You cannot imagine such a interesting topic talk on AI like that. So we are proud to have you, sir. You have all along been supporting us, and you request you to continue to do so in the following years. And next year, Dr. T.P. Sudhakar and Dr. Suresh Kumar again are joining in our RCBC inauguration, Research Capacity Building program inauguration on 27th morning, 11 o'clock. Again, wherever we go, we will take with you, sir, and you kindly guide us. And I am happy that Dr. Raman, young psychiatrist and professor of psychiatry in Savitha Medical College, has chosen a good topic about glutamate in depression. People talk about glutamate in schizophrenia. So this is what our WISER program is all about. And we need not tell about Dr. T.P. Sudhakar. He was always a mentor, encourager for young generation. And we continue. We request you to continue to guide us, sir. With these few words, I request you to take over the session, and the chair is with you, sir. Welcome, Dr. Sudhakar, sir.
Thank you, sir. Our president, Dr. Ramakrishnan, sir, CME chair, Dr. V.K. Aravind, and his co-chair, Dr. Lokeshwar Reddy, I could see him, and other members of the CME committee. It's really a very big honor to me to preside over the very next meeting after which, when we had the last meeting last month, when we had honored one of our esteemed members, Dr. Gangadhar. And the very next meeting, I am chairing the session. That itself is a honor. That too, when Dr. Suresh Kumar and another eminent young speaker, Dr. K. Raman, are participating in this particular meet. I'm really honored. Thank you, Dr. Aravind and President, sir, for this honor. We will straight away go into the topic. Today, our program is, we have got two lectures. One is about the role of glutamate in depression by Professor K. Raman of Savitha Medical College. And of course, the other one is on treatment-resistant depression by Dr. M. Suresh Kumar, about whom I need not really introduce. But it is such a stimulating topics which have been chosen by our chairperson for this evening. And as you all know that we had been treating depression for times immemorial. And at some point of time, probably the basic theory was monoamine theories. And we had monoamine inhibitors to start with. Then we switched over to tricyclics. Then we are going through the period of SSRIs, wherein we think that by altering the monoaminergic transmission, we can treat most of the affective disorders. But despite our efforts with all these new molecules that's in the field right now, we are not fully satisfied. That's why Dr. Suresh Kumar is going to talk about the treatment resistance. That means there is still certain cases wherein the available antidepressants are not sufficient to treat. So that means something else is underlying, whatever may be the etiology of depression. And our focus immediately shifted to glutamate, because as you know, maybe glutamate and glycine, they're almost like twin brothers, and most of the NMDA receptors, they act together whenever these two substances are there acting on that particular receptor. And our main focus is how glutamine could probably affect depressive patients. The various mechanisms have been suggested, and the very example we came to know rather in late 2000s is about ketamine. Ketamine is a very staunch NMDA antagonist, and people came to know that ketamine is quite effective and very immediately effective, unlike the routine antidepressants which we are dealing with in treating the depression. This really was a breakthrough, because till that time we had other NMDA antagonists like memantine. Memantine really doesn't act that effectively as ketamine. So we think that the very glutamate metabolism itself in the brain is quite tricky. Unless we know the underlying mechanisms, probably we can't understand how glutamate could be very relevant in treating a depression. Probably initially Dr. Kumar, which were there in the market early in 90s. And actually these two drugs are not reuptake inhibitors of serotonin or norepinephrine. They are in fact enhancers of reuptake. Despite that, they were proven to be quite effective, and now the theory is probably its action is basically based on again NMDA receptors. So again, probably this tianeptine is going to come back into the market in a big way as an NMDA antagonist, as an antidepressant. And only problem with tianeptine, probably some of us have experienced, is they have got some abuse potential. Again, Dr. Suresh Kumar is the right person to talk about this abuse potential, whatever it has got. So without standing between you and the speakers, I will first switch over to the first speaker who will be talking about the glutamate role in depressive illness and maybe some of the glutamate related drugs which modify the glutamate metabolism in depression, Professor K. Raman. He is a young man. He is MBBS from Madurai Medical College. He did MD Psychiatry from Kasturba Medical College, Manipal. He has got a postdoctoral fellowship in Child and Adolescent Psychiatry, CMC Vellore. And currently he is Professor, Savita Medical College and Hospital, Chennai. His achievements are, he had got a travel fellowship award for WPA meeting in 2010 as a young psychiatrist. He had got a Best Poster Award in Tamil Nadu Psychon in 2015. He has achieved a Nilofer Award for Early Intervention Autism in Indian Association of Child and Adolescent Mental Health Conference in 2016. His main areas of interest is, of course, like me, he is interested in postgraduate training. Of course, from this CV, you can decipher that his main area of interest is probably child and adolescent psychiatry and all problems related to childhood and adolescence. With the short introduction first, we will go over to Dr. K. Raman for his deliberations on glutamate metabolism in depressive patients. Probably based on that background, Dr. Suresh Kumar may be elaborating on treatment-resistant depression. Over to you, Professor K. Raman.
Yes, sir. Sir, is my screen visible?
Yes, sir.
Yes, sir. Sure, sir. And thank you so much, sir. At the outset, I would really like to thank IPS President, Southzone President, Dr. Ramakrishnan, sir, and CME committee members, Dr. Aravind, sir, and Dr. Shantin MD, ma'am, for giving me this opportunity. With due respect to the chairperson and the speaker, Dr. Suresh, sir, I would like to proceed. It's really indeed an honor to present in front of all senior psychiatrists. So I feel extremely privileged to do this topic. Like some audio disturbance was there. Okay. So the topic that is that I've chosen to present for the today's CME is focus of glutamate in depression. So this is the outline that I would just present in. Like I'll just give you a brief background of why we started focusing on glutamate and the basics about glutamatergic system, which is extremely essential to understand the receptor mechanism. And possible evidence for glutamate dysfunction in major depressive disorder. I'm not going to go into details of all the drugs, but I'm just going to give a way for just introducing some of the glutamate targets and for depression. So as the chairperson rightly pointed out, our knowledge about etiology of major depressive disorder has evolved over decades. So we started with understanding of monoamine deficiency, and that was a major theory of depression a few decades back. Then we actually expanded our understanding to actually cortical and limbic pathology, where there was involvement of prefrontal cortex, amygdala, and hippocampus. And we started later understanding that there are definite structural and cellular level abnormalities in major depressive disorder. And there is definitely a possibility for neurotoxicity role in hippocampus in major depressive disorder. So when we talk about neurotoxicity, of course, the first neurotransmitter that comes into our mind for excitotoxicity is glutamate. So again, when we understand like major depressive disorder, antidepressants have been in existence for a longer duration, but still there are certain unmet needs for antidepressants. That's why we have started shifting on other areas of targets or neurotransmitter targets for depression treatment. So if you just look at a very recent meta-analysis and systematic review on head-to-head trials of various antidepressants, still the study's results were really astounding to see that like most of the major antidepressants have difficulty, they had less efficacy, as well as their tolerability was like questionable. So that comes to a question of like, even on many randomized control trials when it was done, like when a meta-analysis of studies were done, we found out that the placebo response was at least 30%, 30 to 35% like uniformly, which questions the efficacy of antidepressants per se. So that just points out to that limited specific efficacy of the antidepressants, like probably there is just a 20% advantage over placebo. So where are we now, like with regard to the specific antidepressants? That's the reason why antidepressants are being marketed with various receptor targets. We also know that they produce a lot of side effects, and most important symptoms are still not addressed with the currently existing antidepressants, particularly lethargy, anhedonia. We really need to pick up antidepressants, and polypharmacy has become a norm in starting with like certain cases like where there is severe depression. So we all know that like antidepressants have a relatively slow onset of action, which at least takes 2 to 4 weeks for the therapeutic action to start. So which again points to the need for onset of action much earlier. So hence the target for glutamate came into picture. So we all know that the study trial results were like again pointed out, like when the remission rate with first used antidepressant was around 36.8%, which gradually dropped at the when we started using the fourth antidepressant, it came down to 10.8%. So this is the reason why actually there is a new target for antidepressant action is essential. Thus came into existence glutamate. So why focus on glutamate? So glutamate is the most potent excitatory neurotransmitter available in the brain. Compared to the monoamines, which are available in millimole, glutamate available or concentration in brain is like 5 to 15. Monoamines are available only in micromole concentration, whereas glutamate is available in millimole concentration, which is around 5 to 15 millimole per kg. So such is the amount of concentration of glutamate available in the brain. So definitely it has a significant role on various aspects of the brain function. So one of the most important role that we are all aware of is like synaptic plasticity, learning, and memory. So when we learned about synaptic plasticity, we must have heard about this long-term potentiation and long-term depression, which plays a vital role in synaptic potentiation. So there is a huge research available with regard to glutamate involvement in neuropsychiatric neurological disorders such as amyotrophic lateral sclerosis, like for which riluzole is the drug of choice, like which has been identified as a glutamate antagonist. So although these research exist like in evidence, when it comes to psychiatric disorders, like still an understanding of glutamate is lacking, particularly with the focus more was on schizophrenia. Slowly we have started actually focusing on the role of glutamate in not only depression, but also in anxiety disorders, particularly PTSD, OCD. Recently, I think we had a talk from Nimmans, like where they just talked about like the role of memantine in treatment-resistant OCD. So such is the implication, wider implication of glutamate that we are looking at. As Sir said, like it is as complex as our human brain, glutamate neurotransmitter itself, because in view of its action on various receptors, understanding glutamate receptor itself can be a CME lecture of its. But major
Some trouble.
yes, sir.
Can you request
Can you please-
whoever is managing to mute everybody?
Sure.
Rajesh, I think you can mute everyone, Rajesh.
Yes, sir, I have done.
Yeah, you can mute it, okay? Because some people are coming in the speaker link. I don't know how they got this link. So this is not a common link to be done. Okay, Dr. Raman, you please continue, Dr. Raman.
Sure, sir. But the major compelling evidence for the role of glutamate in depression came after ketamine's efficacy was established. And also there is a lot of link between the role. There is a lot of link established between antidepressant effect, because it said that the delayed effect of antidepressant, although the acute effect of antidepressant is to increase the substrates, monoamine substrate, whereas the delayed effect was actually possibly mediated through glutamate. That's the reason for delay in effect. So before we understand the glutamate signaling between the neurons, it is important to know the glutamatergic system. So when we talk about glutamatergic system, like we always talk about tripartite glutamate synapse, which is like presynaptic neuron, postsynaptic neuron, and the glial cells. This constitutes a glutamate synapse. So which is always tripartite, whereas in most of the cases we would have not had an involvement of the glial cells, which is very important in the role of neurotoxicity and synaptic plasticity. There are two important types of glutamate receptors. One is like ion channel receptors, which are called as ionotropic receptors. The other one is metabotropic receptors, which are G protein coupled receptors, which are almost similar to dopamine, norepinephrine, and serotonin. This is a classification of glutamate receptors. As I told you, it's into ionotropic and metabotropic. These ionotropic receptors are further classified into NMDA and AMPA and kinase receptors, whereas metabotropic receptors are classified further down into group 1, group 2, and group 3. Based on the subunits, they can be further classified. The most important modulator that is required in terms of antidepressant efficacy is N-glutamate R2 and R3 group. This group is extremely focused on target for antidepressant action. These are the subunits for each receptors. I'm not going to details, but like NMDA receptor has receptor 1 and receptor 2 with subunits of A to D and receptor 3 of A to B. So similarly, AMPA has 4 receptors like subunits from R1 to R4. So as I told you, metabotropic glutamate receptors are further classified into group 1, group 2, and group 3. Group 1 are primarily excitatory, like they actually activate adenyl cyclase and protein kinase C, whereas group 2 and group 3 are primarily inhibitory in nature. This is an important picture that we need to understand for the glutamate signaling between the neurons. So this will summarize the glutamate metabolism. So if you just see that this is a presynaptic neuron, this is a postsynaptic neuron, these are all glial cells. So if you just see that like the source of glutamate is not just purely from glutamine, they are also metabolized from, they are also produced from the alpha ketoglutarate and pyruvate from the KCA cycle. So this is not the only source. Glutamine is not the only source for glutamate. So glutamine is converted into glutamate in the presynaptic neuron by the enzyme glutaminase. So this glutamate, which is actually further encompassed into the synaptic vesicle with the use of, this is a very important transporter protein, which is called as vesicular glutamate transporter protein, which helps in packaging of the glutamate into the synaptic vesicles. These synaptic vesicles, by association with this membrane, presynaptic membrane, through the SNAR complex. This is again a protein which is essential for regulating the presynaptic membrane. By association of these vesicles with through the SNAR complex, when the calcium exocytosis happens, these synaptic vesicles release glutamate into the synaptic cleft. The synaptic, once it is released into the synaptic cleft, they actually glutamate get their activation. glutamate mediate their action through their glutamate receptors, which are available on the postsynaptic membrane. You can see NMDA receptors, you can see AMPA receptors, you can see kinase receptors. So they mediate their action through the receptors. Okay. So once the glutamate gets attached to the postsynaptic membrane, there are certain proteins on the postsynaptic membrane which are called as postsynaptic. So there are postsynaptic membrane proteins which are called as postsynaptic density proteins which are attached to the postsynaptic membrane. They help in mediating regulation of the receptors. So once the glutamate executes action through the receptors, there is increase of BDNF release, and which helps in further intracellular activation of intracellular cascade mechanisms and results in synaptic plasticity. Once this response is done, the excess glutamate that is in the synaptic cleft is actually removed through very important transporter which is called as EAAT, that is excitatory amino acid transporter. So this is extremely important because these are all important channels for antidepressant target. So excitatory amino acid transporter, what it does is it removes the excess glutamate from the synaptic cleft back into the glial cell, where the glutamate is converted into glutamine by glutamine synthetase, and which is taken back into the presynaptic neuron. This completes the metabolism of glutamate. If you just look at the same glutamate signaling, depending upon the receptor, basically what happens is the NMDA receptor and AMPA receptor, NMDA receptor primarily conducts through calcium channel, whereas AMPA receptor primarily conducts like depolarization through sodium channel influx. So once this channel influx happens, this results in activation of the BDNF release and further synaptogenesis happens. So you can see that like these are all kinase receptors, NMDA receptors, AMPA receptors, whereas metabotropic glutamate receptors, like I told you, metabotropic receptors are G protein coupled receptors, are available both on the presynaptic neuron as well as on the postsynaptic neuron. Whereas you could see that NMDA and AMPA receptors are predominantly on the postsynaptic membrane. So just to give a brief overview about each receptor, I'm not going to elaborate because like it's going to take much of the time. So the NMDA receptor is extremely structurally complex. If you just look at this, this is the NMDA receptor, which is a tetrameric complex. This is a receptor 1 subunit, 2 receptor 1 subunit. This is receptor 2 subunits, which are 2. This is a primarily glycine binding site, and this is basically glutamate binding site, receptor 2A and 2B. So NMDA receptor activation happens only if both glutamine and glycine combines together. NMDA receptor activation cannot happen with just glutamate activation or glutamate receptor with just the glutamate presence. So it has to have a glycine presence. That's why glycine is called as an obligate co-agonist for presence of activation of glutamate receptor, which is NMDA. At resting membrane potential, magnesium actually blocks the influx of calcium. Once the membrane gets partially depolarized, it allows the influx of calcium, which leads to further intracellular cascade activation. So the most important point is like NMDA receptor in moderate level. This is one receptor which is have to be focused because like it focuses on like maintaining optimum level. So when there is NMDA receptor moderate activation, it leads to synaptogenesis. When there is excessive NMDA receptor activation, it results in excessive calcium release, which can result in apoptotic processes or cell death. So this is again the same receptor, like just to give a brief idea of like there are different sites for binding for glutamate and glycine. So there have been reports of like altered NMDA binding and expression in individuals with major depressive disorder. So in major depressive disorder, it's not like each receptor malfunction has been identified from various studies. So the most important finding that they have found out is also decreased transcription of excitatory amino acid transporter. I told you this transporter is extremely important for removal of the excess glutamate from the synaptic cleft. So all these have been identified as abnormalities in major depressive disorder. Coming to AMPA and kinase receptors, they are non-NMDA receptor. The most important function of AMPA receptors are they mediate the fast excitatory neurotransmission, whereas NMDA receptor mediates slow excitatory neurotransmission. So it is said that like AMPA and kainate receptors get activated in less than a millisecond, and they get desensitized also very faster, whereas NMDA receptor takes a very slow time to actually get activated, and their desensitization also takes a longer process. That is why they are responsible for slow excitatory neurotransmission, whereas AMPA is responsible for fast excitatory neurotransmission. Kainate receptors are present both on the presynaptic and postsynaptic neurons, but like they are predominantly presynaptic, they are predominantly present on the presynaptic neuron. These are metabotrophic receptors. Like metabotrophic receptors primarily act via the G proteins, like rather than the cation channels, which are for the inotropic receptors. This is just the key features of metabotrophic glutamate receptors. They are classified into 3, as I told you. Group 1 is for like activation of phospholipase, and group 2 and group 3 are for inhibition of adenyl cyclase. The most important is like they are present on the presynaptic and postsynaptic receptors. So the modulation of, they can actually affect both glutamate release from the presynaptic neuron as well as like activation of the receptors on the postsynaptic neuron. So that is why this is a major area of modulation for antidepressant therapeutic action. This is extremely important. That's why, because like there have been new targets on excitatory amino acid transporter enhancer, which is ceftriaxone, which is an antibiotic, ceftriaxone. This has been found to be also effective in that to produce antidepressant action. So there are studies which have been found that like decreased expression of EAAPs have been found to be present in mood disorders, whereas increased expression of these transporters have been found to produce antidepressant-like effects. So we all know that like lamotrigine modulates glutamate transmission. So they have found that like actually one of the most important mood stabilizing property of lamotrigine therapeutic action is mediated via upregulating this particular transporter activity. So that's why we are giving them as a drug of the therapeutic choice in bipolar depression. So these are all the various types of EAATs. Again, like each one is distributed at different places. One can be specific for glutamate and aspartate, and other can be for glutamate. So like that, we have 5 different subtypes. Vesicular glutamate transporters, these are very important because, as I told you, in the presynaptic neuron, the glutamate is stored in the synaptic vesicles, which is actually through the process of the transporters. Again, decreased glutamate mRNA expression has been identified in patients with MDD, major depressive disorder. So this is again an important area which can be identified for therapeutic action. The postsynaptic density proteins, this is extremely important for regulating receptor activation. So like ISO is presynaptic, like you have what is called a SNAR protein complex. We have on the postsynaptic membrane, you have what is called as postsynaptic density proteins. There are different types of proteins, but what is more specific for NMDA receptor activation is PSD95 and SAP102. So these levels also have been affected in patients with like depressive disorder. The glial cells, like without glial cell, the synapse of tripartite glutamate is incomplete. So glial cells plays a vital role in metabolizing glutamate to glutamate. Then they also synthesize and release the NMDA receptor coagonist D-serine. They play a vital role in clearing glutamate from the synaptic. The excessive glutamate, if it is there, then they are going to, more that glutamate and the more severe the excitotoxicity. So they are going to play a vital role in removing the excessive glutamate from the synaptic cleft through their EAAT that's the transporters. So there is a lot of literature available on the role of glial cells, astrocyte dysfunction. They've even looked at the morphology of the astrocytes, which has been found to be defective in patients with depressive disorder. So to summarize the role of glutamate in psychiatry, of course, like there are, as I just started, like you can have anything related to schizophrenia, depression, bipolar disorder, post-traumatic stress disorder. So the expansion of glutamate role in psychiatry is expanding. So that is why we have just started focusing on, apart from schizophrenia, we're just looking at other disorders and targets for glutamate. Now, there is the evidence for glutamate dysfunction in mood disorders. So the most compelling evidence is from ketamine studies. So like we all know that ketamine is an NMDA receptor antagonist. So many people get confused because like NMDA receptor is not equivalent to glutamate. So it's a receptor where the glutamate gets bounded to. So that is where the confusion comes in understanding the role of or antidepressant effect of ketamine. So NMDA receptor antagonist, but it potentiates AMPA receptor mechanism. So basically we should because the fast excitatory transmission is through the AMPA receptor. Just now I said that like AMPA receptor is responsible for fast excitatory neurotransmission, which further regulates BDNF release and which further regulates the synaptic plasticity. So this faster action of ketamine is because of this AMPA receptor potentiation, because the NMDA receptor is blocked, so glutamate gets bounded to the AMPA receptor. This is the most compelling evidence that we have for any other psychiatric disorders. Most of the studies come from the psychotropic drugs. So similarly, we started having the compelling evidence from ketamine. So we also know that there are certain drugs which are going to inhibit the glutamate release. Some of them are riluzole, as I told you, it was indicated in amyotrophic lateral sclerosis. This lamotrigine, they have demonstrated antidepressant property. Although memantine, as sir was saying, memantine has been tried because of this. This is also an NMDA receptor antagonist, but like efficacy wise, like they are not been proven yet. So memantine studies have not been proven in terms of like antidepressant property. The other ways where they found out evidence for glutamate dysfunction in depression or major depressive disorder is they have found that like abnormally elevated levels were found in depressive patients, which was primarily through magnetic resonance spectroscopic studies. And most of the studies were from animal models or postmortem studies, or like, of course, like clinical studies and human studies have started already. And there are a lot of evidence available in the literature. So there is a significant role of association between glutamate, stress, and depression. So if you just look at like how stress mediates, like stress actually increases like associated with increased release of glutamate. So they can have an acute stress which is mediated through which can be mediated through the neurons which are projected to the prefrontal cortex, whereas the chronic stress is where like glutamate comes into picture. It results in increased release of glutamate. It has altered clearing of glutamate from the synapse. That means like there is going to be more glutamate in the synaptic cleft, which is going to cause like cell death and reduce glutamine cycling and glial cell density. These are all produced by like chronic stress effects. So you could just see this like chronic stress actually decreases glutamate synapse number and function. These are all the postsynaptic density proteins, the vesicular glutamate transporter. All these are impacted by chronic stress. So if acute stress doesn't actually mediate through the glutamate receptor function. So you could see here, ketamine actually produces glutamate burst and glutamate synaptic plasticity, whereas stress and cortisol decreases BDNF. So very, very important is like chronic stress actually plays a vital role in actually mediating effects in depression through glutamic neurotransmission. One of the most consistent findings that have been demonstrated in imaging finding is like the elevated glutamate levels like have been found in occipital cortex, and decreased level has been demonstrated in dorsolateral prefrontal cortex and anterior cingulate cortex. This is one of the most important finding through magnetic resonance spectroscopy. Of course, like as I just said in the beginning, like antidepressant effect, the acute effect of antidepressants may be to focus on increasing the monoamine substrate, whereas the chronic effect, there are a lot of studies which are focused that the delay in onset of action could be mediated through glutamate. So lot of studies which are focused on like how antidepressants are going to affect the glutamate function. So one of the ways is they reduce glutamate release and synaptic transmission. Some of the antidepressant effect have been mediated through reducing glutamate release and synaptic transmission. They have been found to prevent the stress-induced enhancement of glutamate release. These are all some of the ways, and some of them can actually alter the expression of mRNA that codes for NMDA receptor subunits. So again, like how we just learned for ketamine, which is one of the rapidly acting antidepressants. So the antidepressants which are supposed to mediate through glutamate should reduce NMDA receptor function but potentiate AMPA function. So if you just look at here, the typical monoamine antidepressants, they increase monoamines, but the BDNF expression, but they don't affect the release. Whereas the major difference between rapidly acting antidepressants and the monoamine antidepressant is rapidly acting antidepressants through AMPA receptor activation produces a glutamate burst and then increases BDNF release directly. It doesn't just affect the expression of the BDNF alone, whereas it actually increases the BDNF release and improves the synaptogenesis. That's why the faster onset of action for rapidly acting antidepressants. These are all some of the sites that have been looked at for glutamate targets. One of the first important site is the antidepressant should target presynaptic release of glutamate, the first one. The second one in the receptor level, postsynaptic receptors. The third one is the metabotropic glutamate receptors. As I was repeatedly saying, like it must be either 2 or 3, and there are studies on 4 of the 1 and 5. And the last one is the EA80, the transporter. So these are all some of the 4 major targets for antidepressant therapeutic efficacy, which have to be mediated via glutamate. Of course, some of them just complete the other evidence. I just wanted to highlight that there are a lot of animal models which have highlighted the importance of glutamate in depression. One of the most important, many studies have been done in rats, mice, and all those things. Like we could see that the vesicular glutamate transporter decreased expression have been found repeatedly, and involvement of metabotropic glutamate 3 receptor decreased expression have been found in animal models. Postmortem studies have contributed to the evidence for depressive disorders. So you could see that predominantly they have just noticed NMDA receptor 2A, there is not much of evidence for NMDA receptor 1 subunit, whereas there is a lot of evidence for NMDA receptor 2A and 2B. This decreased expression have been found in patients with major depressive disorder in postmortem studies. Whereas when it comes to imaging, you could just see that magnetic resonance spectroscopy focus on they were not able to just measure only glutamate alone, because it's always glutamine plus glutamate. So that's why it's GLX points to glutamate plus glutamine. So there is a decreased glutamine level in the major depressive disorder in prefrontal cortex and anterior cingulate cortex. So the major study that has been found is decreased glutamate level in the anterior cingulate cortex. When it comes to PET imaging, they found out that there is decreased activation of metabotropic glutamate receptor 5 in anterior cingulate cortex, orbitofrontal cortex, amygdala, and hippocampus. So some of the imaging studies have also found out that there is a decreased glutamate release or glutamate levels of glutamate in these anterior cingulate cortex. Whereas blood levels in the plasma have been measured, and the meta-analysis of some 12 association studies between blood glutamate level and MDD has clearly pointed out that blood glutamate levels in depression is high. This is what has been found out through blood levels or plasma levels of glutamate. So the most convincing evidence is through ketamine. So understanding ketamine mechanism of action is extremely important. One is through the NMDA receptor blockade, as that is the most important mechanism, NMDA receptor antagonist or NMDA receptor blockade, which increases glutamate release and it causes activation of. So once the glutamate is released in the synaptic cleft, it causes activation of the AMPA receptors, so which is responsible for the fast excitatory neurotransmission and which increases the BDNF release, and BDNF binds to related kinase receptor, and there is an intracellular signaling pathway which is called as mTAR, which is again very important when you have to understand glutamate related therapeutic effect. There is another mechanism of action which is also contributed to the ketamine effect through blockade of GABAergic inhibition, so which disinhibits the glutamate release, which leads to surge of glutamate release, and of course further release is through the further action is through the AMPA receptor activation. So this is one of the this is one of the picture which is very interesting to note that with the dendritic spine arborization, you could see that with chronic stress where there is decreased, and with chronic stress and ketamine, how ketamine could just increase the dendritic arborization. So that comes to the understanding of where all and what all have been done for glutamate targeted interventions. I've not got enough evidence based for all the individual drugs, but I just thought I will just summarize some of the targeted interventions. NMDA receptor antagonists, like just now we just learned, one of the most evident drug that has been studied repeatedly. You know that ketamine is FDA approved in 2019 as intranasal spray. So ketamine and long-term maintenance studies of ketamine is also available. So then comes memantine. Of course, the efficacy has not been very clearly established. Zinc and magnesium are, because they are addressing membrane potential, their blockage is essential for NMDA receptor functioning. There can be positive modulators, because just now we learned ketamine actually potentiates the AMPA receptor, which is responsible for the fast excitatory neurotransmission. I was talking about EAA2 enhancer. There are a lot of studies that are pending to understand this mechanism much in detail. There is an NMDA receptor modulator, which is minocycline, and the other NMDA inhibitor, antagonist of NMDA, AMPA, and potentiator of glutamate reuptake is riluzole. Riluzole studies have also been found to have some effect, but continuous efficacy studies have not been reported. So if you look at the other important targeted intervention is the drug target is D-cycloserine. We know that glycine is a co-agonist with the glutamate. So the glycine site of NMDA modulation has been targeted through D-cycloserine. The others have been dextrometamorphin, because that also acts through NMDA antagonism. Quinidine combination is under development. These are all some of the studies. Some of them are in the phase 2 and phase 3 trials, but efficacy has been proven consistently for ketamine and S-ketamine. So to summarize, definitely there is a significant amount of role of glutamate in depression, which is very well established from whether it's from animal models or postmortem studies or from human studies and imaging findings. And this is a very complex neurotransmitter, but the advantage of it is targets can be focused on individual receptor and subunit modulation. And definitely there is a huge scope for rapidly acting antidepressants. So one of the most important pioneer for that is ketamine, but there are a lot more to actually come. With that, I would like to actually end my talk. Thank you so much for your patient listening, sir.
Thank you very much, Dr. Thank you very much, Dr. Raman.
Thank you, sir.
For your elaborate presentation on glutamate, metabolism as such, and its role possibly in various depressive illnesses. There is no denial that we have to move above monoaminotic transmission in depression, because as you rightly said, ketamine is one evidence. Maybe there are other pointers also that monoamines not alone are responsible for depression, because we see various types of depressions. We see agitated depressions. We see depressions in stupor also. Maybe again here, various glutaminergic transmission plays a role. Maybe in some of the agitated depressions, it may be glutaminergic excess. Maybe in retarded depressions, it may be lesser levels of glutamate. Maybe the various receptors, not only the receptors, for that matter, glutamate, even within the neurons also, it can just transmit. So that is another problem with glutamate. Probably one of the most ill understood neurotransmitter as far as we stand today is glutamate. Maybe. That's why so much of confusion is there. Anyway, definitely time will solve. The progress had been very rapid. As you rightly said, some of the NMDA antagonists, they don't act as antidepressants, whereas ketamine acts maybe by a different mechanism. You are true. That's right, probably. We will wait for the questions till we complete the other topic by Dr. Suresh Kumar. Okay for you?
Yes, sir. Thank you, sir. Yes, sir.
Okay. So all the questions may be kindly posted. We will discuss about both the topics because they are interrelated. There is no point in discussing it alone because there will be a lot of superimpositions. So we'll move over to the next topic. This is about the treatment resistant depression by Dr. M. Suresh Kumar, who is adjunct professor of psychiatry in Sri Ramachandra Institute of Higher Education and Research. He is also director of SciMed Hospitals in Chennai. He doesn't really require any introduction as far as I am concerned. Of course, I am very close to him. But for the benefit of youngsters, you should know that he is a globetrotter. He had been virtually to every corner of the globe, spreading the message of drug abuse, how to handle this big menace in the society. He is a Humphrey Fellow in Substance Abuse, Johns Hopkins University in USA. He had got extensive involvement in the field of mental health and substance abuse as a service provider, as a teacher, as a trainer, as a researcher, and an international consultant. Actually, he is a consultant to many of the developing and developed countries also. He is working with various international institutions on this particular topic and also with UN organizations, including UN AIDS. So he is also into the HIV field because, as you know, some of the HIV patients could be because of injection, they are injection users. Then he has assisted rather substance use disorder prevention, as I said, in many countries, including our neighborhood, Afghanistan, Bangladesh, Bhutan, Iran, Kazakhstan, Laos, Malaysia, Maldives, Mauritius, Myanmar, Nepal, Sri Lanka, Thailand. You name any country in Southeast Asia, probably he had been a consultant to them. He had published many articles, more than 60, in international and peer-reviewed journals. He is on the editorial board of International Journal of Drug Policy as such. So his main area of interest from this brief biodata, whatever I could get, is probably drug abuse. But today he will be talking about a different aspect. After all, he is a clinician like us. And as everybody had been talking about, he is probably one of the prolific speakers who can talk about anything for any number of hours. In that way, probably I adore him for that. Without wasting much time, already I have wasted probably. It's over to Suresh Kumar sir. Welcome.
Thank you. Thank you very much, sir. I hope I'm audible.
Yes, sir. Yes, sir.
Okay. Thank you so much for your kind introduction, my close friend, Dr. Sudhakar, sir. At the outset, I want to thank Dr. Ramakrishnan and Dr. Arvind in particular for inviting me to the CME. I'm pretty excited to be in the company of Dr. Raman. So first time I'm listening to him, and I think it was a brilliant presentation for a young professor. I went into the details of it, very complex topic, but I think he really had a very lucid presentation. Thank you, Raman, for highlighting on some of the most complex issues. So my job for the 30 minutes would be to talk about the management of treatment-resistant depression. My outline would be, I'll first talk about the challenges in the management of depression, which Dr. Sudhakar very clearly outlined. And I'll talk about what is treatment resistance and the characteristics of it. Then I'll talk about the pharmacological options we have in managing TRD. Then I'll go to the somatic therapies, which are becoming more and more relevant in TRD management. And I think I will rush through the biomarkers because this is going to change the way we understand depression and management of TRD before concluding. So that'll be my outline. First, I'll talk about the challenges. I think we need to understand major depressive disorder is indeed primarily a brain disorder. So all of us need to be very clear about the neural substrates that underlie the affective processes in the brain. And these are very important, both cortical and subcortical substrates. The cortical substrates, some of which Dr. Raman alluded to, the prefrontal cortex, the cingulate gyrus, the subgenial cingulate, the fornix are all very important. And then in the subcortical area, we have the amygdala, hippocampus, nucleus accumbens in the ventral striatal area is very important. And the junction box between the cortex and the subcortex, the thalamus, is also critically important. So these are all the various structures everyone must be familiar with in order to understand major depressive disorder. And this is a wonderful article in Lancet 2012. I always quote this article whenever I present on depression because it's not been superseded later on. If you want to understand the neurobiological substrates that are relevant to MDD, there are certain areas we need to concentrate. Let's look at the cortical structures. The ventral and dorsal lateral prefrontal cortex, the dorsolateral prefrontal cortex, which is very relevant for treatments, and the ventrolateral prefrontal cortex, these two areas are critically important for voluntarily regulating our emotions. We can regulate our own emotions voluntarily only because of these neural substrates. And then there are certain medial structures in the cortex, which are like medial prefrontal cortex, anterior cingulate cortex, orbitofrontal cortex. These medial structures in the brain are responsible for automatic regulation of emotions. You get up in the morning, you feel low. You get up in the morning, you feel cheerful. That kind of a regulation is controlled by that neural substrates. And there is another important process in the emotion, which is the emotion and reward processing. That is actually by the subcortical structures, primarily the amygdala, which is the emotional seat, and the adjoining areas in the ventral striatum, particularly the nucleus accumbens and hippocampus. So you need to understand the neural systems that are relevant for voluntary regulation, automatic regulation, and the subcortical structures which are involved in the emotional processing. Today, all the management is focused on, the focus is on dorsolateral prefrontal cortex. It's readily accessible through our surface anatomy. It's very easy to figure out the dorsolateral prefrontal cortex. We can target the dorsolateral prefrontal cortex. That's why we can take it as a treatment target. And then it's a very complex disorder. Depression is a very complex disorder. As Dr. Sudhakar said, no two patients are the same. They are completely different symptomatology, yet you make the same diagnosis of MDD. That's the biggest problem that the clinician faces. That's what the patients also come and ask. You diagnose this with my friend who had a different manifestation. You are diagnosing me with depression. I have a very different manifestation. How is it we're all the same condition, suffering from the same condition? So that's a complex disorder because the whole etiology is contributed by many factors. It could be at the gene level. There are certain candidate genes. Particularly, the candidate gene could be anything. It could be a neurotransmitter related, or a neurotrophic factor related, or a HPA axis related gene, or it could be a circadian gene. And then at the molecular level, there are neurotrophic factors, the pro-inflammatory cytokines, the impaired regulation, dysregulation of HPA axis, which has been traditionally talked about for several years from 1970 onwards in depression. All are very important at the molecular level. And then there are this neural system level disturbances that I talked about, the amygdala, the ventral striatum, the medial as well as the lateral prefrontal structures. So all of this become very important in the neurobiology of depressive disorder. That comprehensive understanding will tell us why all people will not respond to the treatment that we have at this point in time, which is a point that Dr. Raman was talking about, one aspect of it. Now let's talk about what is treatment resistance. How do we understand treatment resistance? Now, if you have an individual with depression, and if you start providing treatment to him, and he's supposed to respond to the treatment that is provided with, so there is a response. But the response may not be complete. Still, there could be subsyndromal symptoms. And then what we are really wanting to achieve is remission. If you do not achieve remission, the individual is not going to progress to recovery, which is what we are all looking at. If you do not take this individual through remission, he will probably relapse, he will not recover, and even if he recovers, there will be many recurrences. So for a clinician, achieving remission for a person in front of him is a key important clinical decision that you need to make. So if you provide treatment, let's say you provide an antidepressant, you provide an SSRI, you are looking for a reduction of depressive symptom. Most importantly, with a scale, because I think objective measures need to be introduced in psychiatry. Clinical assessment is not going to be accurate. So you use a scale, simple scale, like a Hamilton, depressive rating scale, 17 item. If you have 50% reduction, that really means that somebody is showing moderate level of improvement. But if the person is still having residual symptoms, most of them have residual symptoms. The residual symptoms are the ones which produce the risk of relapse in the individual. They actually contribute to the suboptimal restoration of occasional interpersonal functioning. Because individuals are not only interested in symptom remission, symptom reduction, they are more interested in functioning. The family is more interested in functioning. That could only occur when you achieve complete symptom remission. So your desired outcome in a given patient is first complete symptom reduction. So what is remission? Remission, you treat the individual and the individual exhibits residual symptomatology, but the residual symptomatology is essentially indistinguishable from a person who has never been depressed. So typically a score of 6 or less in Hamilton rating scale, in a 17-item Hamilton rating scale, is taken as remission. There is another way of looking at it. You use any scale. If there is a 75% improvement, you call it as remission. If it is between 50 and 75%, you call it as a response. If it is between 25 and 50, you call it as a partial response. Somebody has not even responded by 25%, you call it as a non-response. This is another way of quantifying it. Okay. Now, what are the challenges with the treatment that we have with the SSRIs and SNRIs and TCAs, what we have? First of all, which is the antidepressant you will select for an individual who's sitting before you with the diagnosis of MDD? Is often the clinician's own choice, is based on his own clinical wisdom, but it is a critical choice that you need to make. Should I give an SSRI or an SNRI, because both are called as first-line antidepressants, or should we straight away ask him, because I think that someone intuitively, I should straight away put him on a TCA? We don't know clearly guidelines for that. And then the antidepressants, whatever that is available in the market at this point in time, a variety of them, all of them, the effectiveness is inadequate, which Tom talked about the SARD trial, how many people actually respond to antidepressants the first time, and even with the 4 consequential treatments. And then antidepressants don't work very quickly. That's why you require rapidly acting antidepressants. Raman was talking about it. Delayed onset of therapeutic action is a big problem with antidepressants, particularly when somebody is acutely ill. Safety and tolerability is another issue, but that's why we discontinued with TCAs and we are looking at other molecules. And drug-drug interactions are critically important because any given patient sitting before you in middle age and older age has many more comorbidities. You need to give them several medications. So hence, we should be looking at newer strategies to manage depressive disorder. So what is then treatment non-response? You know what is a response? A person has a symptom reduction following treatment, let's say after a single antidepressant. But if you say it is poor enough that there are significant residual symptoms, maybe even 25% only is improved, then you really think that a change in the treatment is called for. That's simple. That's very called as treatment non-response. Or if somebody is a non-responder or a partial responder, you want to change in the treatment. Whereas by treatment resistance, there is no real validated consensual definition. Each author doing a research on treatment resistance comes up with his own definition of what is treatment resistance. Often it's not distinguishable from treatment non-response. The usual definition, which should be a consensual one in the future, should be a failure to respond to 2 trials with 2 different classes. I've tried an SSRI, I tried an SNRI for adequate time and adequate dose, optimal dose and sufficient duration. Still, the person hasn't responded adequately. Then you call it as treatment resistance. So treatment resistance is a critical concept. So whenever somebody has a TRD, you need to clinically evaluate it. Is it simply to do with the diagnosis? I think Dr. Sudhakar talked about there are different types of depressive disorders. So you need to clarify the diagnosis. Is it depression at all first? Are you doing something else? Are we having so many physical and psychiatric comorbidities which is responsible for the poor response? Is it to do with the pharmacokinetics? Not everybody respond to the medication the same way. If you have a family history, it becomes sometimes easier. My father responded to, this drug, and I probably start the same drug. Medication dose and duration. I said optimal dose and sufficient duration. Adherence to treatment is a most important one. I think a lot of people do not respond mainly because of treatment adherence. We should also look at that important factor. And I think, as Dr. Sudhakar said, the different types of depression, the melancholic, the psychotic, the atypical, the seasonal depressions, they all require different modalities of treatment. The conventional treatments may not work for them. Also, the biggest challenge is when the first time somebody is presenting with depression, you need to ascertain whether they are dealing with MDD or a bipolar depression, which is the biggest clinical challenge for us. Maybe later on you can make a diagnosis, not the first time sometimes. There are clues, there are bipolar questionnaires available, you can easily pick up, but not so easy also sometimes. Now, I'll be talking later on about some of the biological factors which can point out and say even before, like the biomarkers if you have, the biomarkers can actually lead you and tell you how can you identify TRD pretty much early on. So you'll be warned off. You can educate the parents and the people and the family and tell them this is going to be a difficult case for us. The treatment resistance, you can actually predict it. Okay. Now, let's come to the management part of it. Now, talking about TRD, we talked about the challenges mainly because it's a complex problem. It's a brain disorder, but not just a brain disorder, but influenced by many complex etiologies coming together in an integrated way to come to this diagnosis. And we understood about treatment resistance and the challenges to it. Now come to the pharmacological management of TRD. There are 4 important strategies one must be thinking about in managing pharmacologically. One is simply optimizing the medication dose. That was a wise clinician will do. If somebody comes to him and say he's not responded to treatment earlier, the wise clinician will look at and say, what is the drug? Has he got some adequate dose? Has he been given sufficient duration to declare that he's treatment resistant? That's simple. The second one is to go for a switch because he's not responding or he's only partially responding. And then the typical thing all of us do as clinicians is to combine different classes of antidepressants. Intuitively, we combine an SSRI with an SNRI with another drug which is not a SSRI, not an SNRI. Augmentation therapy or adjunctive therapy with non-antidepressants, typically with lithium or P3 or antipsychotics, to increase efficacy. There are 4 strategies. Let's talk about everything. Optimization is very simple. We'll not talk about it. Switching. Where do you do actually switching? We did recently a study in our hospital to look at how many people require a switch. We'll surprise. If you have a patient before you, you start him on an antidepressant, within about a fortnight to a month, he has not responded even 20% in a scale. That's almost an accurate predictor that he's going to be a non-responder and perhaps a treatment-resistant individual. So if you do not see an improvement within a fortnight to 1 month, 20% improvement and less than 20% improvement is only there, a reduction of symptoms is only there, then you are warned and said, this is a good predictor. So this early improvement, if it is not occurring due to other clinical, suppose he is not adhered with treatment or there are other comorbidities, that's a different story altogether. If despite all that, he is having no improvement, then a changement treatment is considered. That's when you consider switch. Okay. So where do you combine? All of us combine, let's say SSRI or SNRI with a dissimilar antidepressant like a bupropion or a mirtazapine, very good combinations. But actually, is there evidence for it? Surprisingly, this often used clinical wisdom is not reflected in the research evidence. So clinicians should be thinking, we may be doing it by practice because my elder seniors did it, other people did it, everybody's doing it. But I think we should also be mindful. There could be other strategies other than combining antidepressants and increasing the side effects of the medication to the individual. We could possibly look at other strategies. So combination may not be really having an evidence, even though it's a common clinical practice. So then the question is, do we switch or do we augment? Where do we switch and where do we augment? The clinical wisdom says augmentation is favored if somebody is partial responder. If there is no response, you need to switch. But if it is a partial responder, you do not want to waste the gain that you have. Because, suppose he has shown some 40% improvement.
Explanations.
Chop the mic of people. I request the host to thank you so much. Okay. Now, how do we switch? How do you augment? Augmentation is favored for partial responders. Because if somebody has been given an SNRI and SSRI, and if they showed about 30 to 40% improvement, not good enough, there you do not want to lose the initial response. So you want to maintain that. Then you perhaps would be better off augmenting rather than switching. Okay. And then if the drug is not at all tolerable, even if the dose symptom reduction is more than 20%, even if it's a partial responder. But if the drug is not at all tolerable, you develop very severe side effects with this medication, if it is poorly tolerated, then you can do a switching. So you need to decide where you have to switch, where you have to augment. So evidence of initial response, as I said, can even be observed. You don't have to even wait. Now clinical wisdom says 2 to 4 weeks, but I think research is now proving you don't have to wait for 2 to 4 weeks. Even in 1 to 2 weeks, you can actually see an initial response. If somebody is not responding within a fortnight, you are free to switch to other drug. Don't waste time, because otherwise you'll be losing a lot of time with the patients, particularly in acutely ill patients. What are the drugs that you augment with? Typically, the first line drugs that we augment with are atypical antipsychotics, lithium for a long period of time. I think clinicians have been using lithium as an adjunctive to augment, and thyroid hormone, not T4, T3. Triiodothyronine is what is really to be added. So T3, if you can add T3, not T4, thyroxine, T3 if it's added, triiodothyronine is added, that is what is actually useful in augmentation for depressive disorder. And in the second line, some of this, like Celecox, which is a COX-P inhibitor, which is probably pointing out to the glutamate pathology that Raman was alluding to, L-methyl folate, modafinil, benzodiazepines, SAMI, all these are probably second line drugs that could be used in augmentation. And then there is probably not much evidence, but it is actually tried in a lot of work and research and even clinically, folates, omega-3 fatty acids, buspirone, lamotrigine, so many drugs have been tried, pramipexole, for example, all these have been combined as, mixed evidence or no evidence for this. Okay, in terms of antipsychotics, you'll find that the greatest efficacy is found for atypical antipsychotics, notably small dose quetiapine, small dose aripiprazole, and olanzapine small dose within about 5 milligrams. These are the three atypical antipsychotics which are found to be very favorable. I think clinicians use it very well. Small dose of quetiapine, olanzapine, small dose of aripiprazole are the drugs that are used as an adjunctive agent for augmenting. And I'm just going to touch upon and say other novel therapeutics which are called as rapidly acting antidepressants, RAATs, are very important. He talked about ketamine. Ketamine is extremely important. We all started to use it clinically, even though direct approval has not come from the Indian regulatory agency. Number of clinicians are using it. It's quite effective in suicidality. Even now we have an inpatient in the hospital, a young girl who admitted to the hospital mainly because of suicidality. Couple of ECTs, would have helped her, but we can't give it because the parents don't want ECT. Obviously, ECT has a very bad press in the minds of people, unfortunately. Ketamine is acceptable to them. These are doctor parents who easily said ketamine is acceptable. Immediately, you can have its anti-suicidal effect on the individual. And that's very important. But we don't know head-to-head comparison between ECT and ketamine with regard to, suicidality. Ketamine is suggested in TRD, and it is a fundamental, treatment at the moment available for dealing with individuals with TRD. Yes, ketamine, as Dr. Raman said, it's approved last year, and it is a nasal spray, and it's going to become very, very popular. If India gets it, I think all of us will comfortably be using ketamine. Other novel therapeutics, as he said, psychedelics are the ones which are all becoming very popular. You must have read about it in all the press, about the psilocybin and the effect of psilocybin. And in TRD, there is a feasibility study which has been carried out in a small number of people with treatment-resistant depression. Here, they're given 2 doses. Initial dose to assess whether the person can tolerate. He doesn't go through more than 6 hours of psychedelic effects. If somebody is going to go through more than 6 hours of psychedelic effect, you'll throw him into psychosis if you increase the dose second time. So these are not good candidates for that. If somebody can tolerate it, the assessment of safety is good in the first dose. Then you give a subsequent dose 1 week later, and then 25 milligrams of psilocybin, which is quite a steep dose. And invariably, people will go through up to about 6 hours of psychedelic experience. But then there is a demonstrated response, even up to 58%, even up to 3 months. So that's a good one. One single dose, 2 doses actually, one therapeutic, one as a test of assessment dose. If you do that, that could be really game-changing treatment for a lot of people. This could become very popular, even though controversial at this point in time, psilocybin. And as Dr. Raman said, I think there are very much useful role for because anti-inflammatories, because after all, inflammation is very closely linked to glutamate, metabolism. And the people who would benefit with anti-inflammatory, not everybody. You should be really looking at inflammatory markers. More and more, we should become like a physician or an oncologist in dealing with our depressive individuals. You run inflammatory markers. If you find elevated inflammatory markers, and I think those are the people who would do very well with anti-inflammatory agents. And then the typical ones are COX-2 inhibitors, tumor necrosis factor antagonists, which is Inflamax, which is given as intravenous infusion, and the neurosteroid, which is brexanolone. Brexanolone now has been approved for postpartum depression. A lot of women with postpartum depression, at least 5% of people with postpartum depression going to TRD. That's the latest research we have on postpartum depression. And here, the neurosteroid, brexanolone, which is really going to rapidly improve their depression and suicidality. So these are anti-inflammatory agents which will become useful at least in some subtype of individuals. Okay. And then there are other novel therapeutics which act on the other systems. We have drugs like buprenorphine, my favorite drug in maintenance treatment. And these drugs are very useful. Buprenorphine is very useful in opioid modulation. And scopolamine injection, intravenous injection of scopolamine, can have a very dramatic effect in some subgroup of individuals. It's a cholinergic modulator. A single dose of scopolamine IV can also have a very dramatic effect on depressive disorder. There is a newly developed GABA modulator, which is called Sage 217, which is in 2020. This is a positive allosteric GABA receptor modulator that could become useful later on because the response rates seem to be very favorable. So there are some novel therapeutics which can be called as rapidly acting antidepressants, because we are really looking at rapidly acting antidepressants. We don't want to wait for a lag period of 2 to 4 weeks before a person responds because it's an acute condition. So I'm done with pharmacology. Simple steps to switch to augmentation with atypical antipsychotics, to considering some novel therapeutics. Ketamine, for example, is easily available. And in the future, some of the drugs like anti-inflammatory and other modulators will become important. We need to also look at somatic therapies in TRD. The well-known, well-established, most researched, evidence-based treatment for TRD is ECT. Clearly, it's gold standard and a clear winner. I don't even know why we have debate on why we should not be considering ECT. After so many years of experience with ECT, it's just a public mindset. It is the way we advocated for ECT. Unfortunately, the movie and the press have not been very kind to us. The depiction of it has been really the reason. And of course, recently the law is also not been very kind in putting such kind of words which makes people very threatened by that. So ECT is widely available. We started this WISER program with Dr. Ganga talking about ECT, and it was a marvelous talk. So we all learned from him and his wisdom that ECT is still the best treatment option available. It's very rapid in severe TRD also. Only thing is the cognitive effects, but we all know as clinicians we can manage the cognitive adverse. One of our postgraduates in Ramachandra did work on cognitive side effects of ECT, and the proof of the thing was it's not a big deal. I think it can be easily managed. Or if you really follow up, it's a good study because it's followed up for a long period of time. A lot of people did not have cognitive side effects in the long run. It's a good news. So the meta-analysis of the ECT plus antidepressants with the antidepressants alone clearly shows ECT plus antidepressants in the meta-analysis is a clearly successful option than antidepressants alone. Or even if you give ECT alone without antidepressants, some people you can't give antidepressants, older people who can't tolerate antidepressants because of drug-drug interactions. Only ECT is option. Give ECT. Or a person who's pregnant sometimes, you give ECT. And then that I think is a great option. I really think, it can have fantastic improvement because, if you look at the efficacy, it's great for ECT compared to antidepressants. There are novel brain stimulation techniques that are becoming increasingly available, increasingly being used. I think all of us are using it. We have been using TDCS, quite extensively. Bangalore Demands is quite experienced. Dr. Ganesh Venkatesupram guidance helped us to develop this TDCS in our hospital. It's a non-invasive technique. It does not do the cortical depolarization. What it does is to modulate the cortical excitatory tone via very weak electrical current through 2 scalp electrodes. Very simple procedure. Some people even buy it in the home and do it at home. 5 sessions of TDCS applied to the left dorsolateral prefrontal cortex will emerge as the most important target area for all psychiatrists. If somebody does not know the surface anatomy, he's not going to get a pass in the postgraduate examination in the future. It's so very important to know where your left dorsolateral prefrontal cortex is. If you don't identify, you can't become a psychiatrist because that's the area you're going to target most of your therapeutic brain modulations. So 5 sessions of it has, compared to sham controlled studies, it's got an effect. Most important thing about TDSS is really well tolerated. Nobody complains about it. It has got no adverse side effects. I think it's a great therapy only because it's relatively innocuous. So people accept it readily. RTMS is becoming very popular. Recently, Institute of Mental Health in Chennai bought it. I'm so happy about it. Nimans came and trained them. So what is the evidence for it? 23 RCTs with sham control, and 6 RTCs with a comparative electroconvulsive therapy have been done. It's a good thing. So we have randomized control trial results available, 23 with sham control and 6 with ECT. What do the trials tell? Trials clearly show there is a statistically significant improvement for with RTMS in TRD. So there is a clear evidence. There is a 10% absolute difference between RTMS and SLAM. What does it sham? It means if you don't provide a treatment and provide RTMS, 5 times bigger. The response rate is 5 times bigger. That's really, really good. So it's very safe both in pregnancy as in older people. And I think we should be considering for people who do not want to favor ECT for whatever reasons, I think you can prefer RTMS in the future. Number of centers in Tamil Nadu, I know about it. I'm sure it's happening in other states also. So other kinds of RTMS is getting, modified. Not the conventional one is the high frequency left dorsolateral prefrontal cortex RTMS. That's a conventional one. Whereas you have this deep RTMS, which means you can even target deep subsets by increasing the target stimulus and the focus and the intensity. You can reach deeper regions, which are very relevant in neural substrates that I talked about earlier on. And the theta bus stimulation, again, they can target very specifically some targets or accelerated RTMS protocols. So these are all available. Accelerated protocol means, you don't have to ask a person to come every day. Instead, in a single day, you go through many sessions. That really helps to get the neuroplasticity quickly in the individual. So changing the neuroplasticity in these individuals is vitally important. That could be achieved by the accelerated protocols where you give many sessions on the same day. Okay, the other options, little more invasive options, are the VNS and DBS. VNS is not good for acute illness. DBS is the one which is becoming popular. If anybody has seen a DBS, we have done it very commonly for Parkinson's syndrome. If you look at DBS, there is a pulse generated beneath the chest, and then I think there is an electrode inside, wherever you want to. So there are clear targets for depression at this point in time. The targets are based on our neural substrate that I talked about, and that one that easily neurosurgeons are currently familiar with. So you can target, for example, the nucleus accumbens. You can target subgenual cingulate. You can target infrothalamic peduncle. You can target even striatum. You can target easily lateral hebinura. So all these areas can be targeted depending on the symptoms. You know where the symptoms are. You know what the symptoms could be related. If you know the neuroanatomy of it, easily you can relate it and advise the neurosurgeon to target that area, and he should be targeting the, like DBS. So comparatively speaking, ECT among the somatic therapies is gold standard. Just uses general anesthesia. It's good for acute clinical efficacy. RTMS is approved for TRD after the failure of antidepressants and no surgery involved. It's good for acute clinical illness. VNS and DBS, probably not good for acute clinical illness. VNS is approved by FDA. DBS is under consideration. I'm sure they're going to recognize it very fast. I think surgery is required in both the cases. Neurosurgeons will be very happy to take on our cases. Non-pharmacological therapies are also very important. Not to forget psychotherapy. Psychotherapy is extremely important to boost the morale and optimism of individuals. Because if you do not boost the morale and optimism of people with TRD, really nothing is going to happen. Many of them are dysfunctional, and we need to address that. I think what is really useful is the cognitive component of it. Cognitive behavioral analysis system of psychotherapy, cognitive behavioral therapy, or interpersonal therapy are now becoming very popular. Mindfulness-based cognitive therapy are all the most effective ones. The bottom line is you always need to combine biological treatments with psychological treatment. Only then it works very well for the patients. And lastly, I will just touch quickly for 2 minutes about biomarkers. So the biomarkers are, simple biomarkers are CRP. If somebody has a CRP level very low, you better give him an SSRI. If the CRP is very high, if you're going to give him with an escitalopram, he's not going to respond. He's not a non-responder because it's not the medication choice is on. If the CRP levels is high, he requires a dual action antagonist. It's a very simple method. We also used it in our clinical setting. We find it extremely useful. What's the initial choice? It's just a simple CRP. CRP high, you start him on SNRI or a PCA straight away. And other markers, inflammation, tumor necrosis factor. If you find the tumor necrosis factor less, more predictive of TRD compared to healthy individuals. And if you have a plasma level of cortisol and cortisol DHA ratios higher, these are more common in TRD. Simple tests all available with us. BDNF, a particular combination of 5HT1A and BDNF genotypes are associated with TRD. One of our postgraduates want to do work in it. I think it's extremely expensive, so she discontinued the study. Monoamine oxidase, we all know that, like some of this dopamine metabolite, like homoaminic acid in this CSF is high in TRD subjects. And what about imaging? If you do a simple structural MRI, in a simple structural MRI, you find a gray matter reduction in the anterior hippocampus. And I think Dr. Raman talked about the importance of toxicity in the hippocampus. Anterior hippocampus reduction, gray matter reduction, is a clinical indicator of, like TRD. And in the vascular brain disease, if you have microvascular neuropathies, individuals with microvascular neuropathies, they are more prone for TRD. Or the functional MRI, the network comprising of left amygdala, anterior cingulate, right insula, and precutaneous cortex, that's a dysfunction there. You can easily figure it out in the fMRI. So these are all ways in which you can find out these are the individuals who probably would not respond to your conventional treatment. Finally, in conclusion, I want to say depression is a very complex, heterogeneous disorder, which is actually baffling to some of us. And then many people do have non-remission. And in the setting of non-remission, you do first simple things like re-evaluate the diagnosis. As Dr. Sudhakar clearly pointed out, adherence is critical. Look at comorbidities. Consider simple things like dose optimization, switching or augmenting. These are the state strategies anybody should employ. Consider novel therapeutics, at least available ketamine. In future, many things will be available. Non-pharmacological treatment, ECT and RTMS are the most robust evidence at this point in time. Combine it with psychological treatments. Biomarkers will become the game changers because the way we understand it will become very important. We can even predict it earlier on. We will be respected more as physicians in the future. I think the rapidly acting antidepressants will also make us feel more comfortable in dealing with people with TRD. And I think the expert clinician is most relevant in dealing with TRD because his compassion, his way of offering optimism and hope to the individual and boosting the morale of the suffering individual with this lived experience is vital in managing people with TRD. Thank you very much for the opportunity.
Thank you very much, sir. Thank you very much, Dr. Suresh. What can we expect from a person like Suresh? You have really lived up to the expectations, sir. It was quite informative, at the same time very lucid and very precise. Thank you very much once again. But before I open it for question and answers, I think one or two things which may be relevant is that we have not yet arrived, like what exactly is treatment resistance. The definitions probably change from clinician to clinician. I think there are at least 2-3 things which youngsters should make sure before they call anything as treatment resistance. One is you have to look at the chronicity of the patient. And maybe the second important issue is, as Dr. Suresh rightly pointed out, it's about the compliance. Maybe third important thing which most of the times we miss is comorbidity. Most of the times we see double depressions. There will be a dysthymia underlying a superimposed depressive episode, and whatever amount of antidepressants you may be giving to these patients, then will never be happy. They will keep on saying that we are still depressed, we are still depressed. Whether to call them as treatment-resistant depression, I don't know really. And at least when we were students, there were intravenous injections of meprotylene, some of the bicyclics and tetracyclics. Those days, apart from tricyclics, we used to promote some of the tetracyclics. Some of them actually have come into Indian market also. I don't know what exactly is the present position of some of these tetracyclic drugs which were given intravenously those time, in that particular time in Europe. Probably Dr. Suresh can respond on that. The other question which I want to clarify from him is, as I said about tianeptine. Tianeptine, still they say that probably it works through glutamate metabolism. I'm not very sure what is the mechanism of action. Maybe with these few things in my mind, I will open it up for the question and answers.
So thank you. If I can quickly respond to the two issues that you talked about. One is the intravenous injections. I'm not too sure whether they are used anywhere at this point in time. For whatever reason, they've been discontinued, we don't hear of them at all. And even, I think I remember, intravenous clomipramine is also available at one point in time where, people were getting the injection anaphylm, and all of them have been discontinued. So I think the antidepressant by needle has gone away for whatever reason. I think now the only thing that we give by needle is ketamine now. So I'm happy that at least
that also is becoming intranasal now.
Yes, sir. So, but with regard to tianeptine, a lot of us use this molecule popularly called in India as Tablon, and then we have used it. And then, it's typically very different from the typical SSRIs. In fact, it has got almost an opposite action. It actually has a very varied mechanisms because, it's kind of a unique one because it's originally I am interested in it because it's an opioid metabolism modulator, but it's a weaker level. It's an opioid metabolism modulator. It acts on the serotonergic. It acts, as you said, on the glutamagic. We really don't know how it works. And then the company will always come and convince us, and then we never, because of the expense, because of the cost issue, we never bought it. We never got to the, a lot of people. But I think the few cases that we have given, I found it interesting. Maybe Raman should highlight whether, how dianeptine, is it the glutamate? And you read the literature, it talks about everything. It talks about serotonergic, it talks about the, GABAergic, it's also glutamatergic. Every modulator is involved in that, including opioid metabolism. I don't know what is primarily acting. I don't even think the manufacturers know anything about it, excepting that they have a clinical trial data showing that it's beneficial. But unfortunately, the market for it is really very poor only because of cost.
I know.
And also, it's very difficult to give. It's like 12.5, PDS and then increase to 25 milligram. I think people have to sell a lot of money. It's not even a dose that can be given once a day. Dr. Shanti wants to say something. Yeah, I think we can go to the questions. And are there any questions?
Okay, then. I think we will start with a question from Dr. Sridhar from Salem. He is asking you about vortioxetine indications in treatment-resistant depression. Vortioxetine.
So, it's another very expensive molecule. It is a multimodal antidepressant. It's actually targeting serotonin, but it is multimodal because there are so many mechanisms that are involved in vortioxetine. It's not like the typical SSRI, which is only have a reuptake uptake inhibition. It has several more actions. And so the multiple actions is supposed to be the beneficial one as an antidepressant. But its role is not been investigated in TRD at all. Vortioxetine has been evaluated for its efficacy in depressive disorder. The manufacturer, Lundbeck, has largely focused it on the cognitive aspect of the drug, in being little pro-cognitive rather than any other stuff, because they can't market it on any other parameter, because it doesn't offer greater efficacy than the conventional antidepressants. So the only way they are marketing it by saying it is not impacting on the cognitive effects like the way other antidepressants do, because it's got the actions which are in favor of a cognitive. So they got, in the trial, they've included very sophisticated mechanisms for assessing cognition. And they have proved that the cognition has indeed shown improvement through the instrument, through the patient versions. And it's a very sophisticated way they've incorporated in the trial itself. That's the biggest advantage I've seen in the trial. In the trial, it's a huge trial involving several countries. In the trial, they made the cognitive assessment, computerized cognitive assessments as part of the trial, in which have shown that there is a cognitive, they're not saying it's a cognitive improvement, the cognition is not being impaired, because cognition is the greatest predictor of functioning. They argue that this drug will be very useful in making individuals functional and recover faster. And so they are actually marketing it for older individuals, because the side effect profile of the drug is least compared to other antidepressants, theoretically speaking. In the real world, some people develop extreme nausea. I've given it to some people who cannot tolerate even a 5 milligram. The kind of a nausea I've not seen with any other antidepressants. So you tolerate it, you are fine. If you don't tolerate, you have nausea, which is a very common complaint, probably only complaint that we need to have. So we need more data to say about drug-drug interactions and other things, how safer it is. It is not a clean drug like escitalopram when it comes to drug-drug interaction or even a desvenlafaxine. But then we are saying at the moment they are clinically irrelevant. We have to only tell over a period of time. But question, mortioxin, is it useful in treatment-resistant depression? No, we do not have evidence at this point in time. It's also very expensive drug. You need to pay a lot of money. If somebody has to pay it on month basis, and when somebody is rich, they cannot afford. Not in COVID times.
You will develop depression again.
The depression will never go. Anyway, the next question, as you rightly said about the COVID, the question is from Dr. Srinivas Raju from Vijayawada. He asks, what is the status of GAD and COVID fever panic in relation to treatment-resistant depression? I don't understand this question as such, but I don't know whether you can reply.
What I understand is, individuals with a existing depressive disorder, existing depressive
having
disorder,
COVID,
in the
maybe
COVID times, they have an additional comorbid anxiety disorder, which can certainly impact on the management. Certainly, we have seen depressive disorder patients have been maintaining very well, particularly the anxious depressive ones. The people who have a extremely good component of anxiety coupled with depression. I think we don't have we have a subtype in DSM, 5 to say, what is the specifier? Anxious distress. So this individual with the depression with an anxious distress are the ones which are probably going to react very, very negatively during the COVID time. It's an unprecedented crisis. So individuals will tend to magnify the threat, will try to get focus on the threat, will try to, maximize their risk assessment, and so will suffer more. And I think these individuals, more than with medication, I would probably say that, they would be helped with psychological treatments rather than just adding another medication. Because adding medication in the COVID time is also going to be very tricky, like the immune storm that occurs in the individuals, it could be very difficult, even though antidepressants are one drugs which are very favorable. Fluoxamine has got a very positive note, and they are investigating about other antidepressants in the COVID treatment. We are all very excited when we saw fluoxamine having a role in managing depression and reducing the severity, reducing the hospitalization. Some good news is finally coming about antidepressants, and the bad press is getting removed thanks to COVID.
Sir, next question I think you have already answered in your talk. This is from Kota Suresh Kumar from Guntur. This is on role of atypical antipsychotics in treatment-resistant disorder. You have already touched upon that. If you want to add anything else.
No, I think the treatment of, the adjunctive treatment or augmentation with antipsychotics have been done with every antidepressant. The complex slide that I showed is a slide that really talked about efficacy versus tolerability. Because people discontinue also if the side effects are more. So it's the ratio of efficacy versus discontinuation, which is reflected on the tolerability. What are the drugs that are tolerable as well as efficacious? For example, risperidone may be efficacious but produce significant side effects. Olanzapine, even though that produces side effects, because of its high efficacy, people still continue with the medication. So things like this, they worked it out in a very complex way. They have arrived and said, small dose quetiapine, small dose olanzapine, small dose aripiprazole are the three antipsychotics which are likely to be combined better in treating treatment-resistant depression.
So next question is again from Salem. Dr. Sridhar asks you about the role of trenylcypromine. Maybe he is asking about MAOA inhibitors in treatment-resistant depression.
I think, that's a great question. I for one believed MAOA inhibitors were a good armamentarium. Even today, some of the intelligent patients, while they're on treatment, they'll come back to you and say, sir, why are you not giving this particular drug? I read in the patient group, there are patient groups available in the internet, and then people talk, I've been getting treatment, I've been receiving all these medications, I'm not shown improvement, what do I do? And then somebody says, what, my doctor, was very reluctant, finally agreed to give me MOI, and then I showed significant improvement. And I think it is a useful strategy. We don't talk about it. In the Western world, MOI inhibitors are very, very unpopular because of this adverse reaction. They eat a lot of cheese. We don't eat any cheese in this country. Where is cheese in India? I don't know. if there is good cheese, tell me the address. So I have no idea where the cheese is. So people don't have so many adverse effects. So I think this is a underutilized medication. Even companies do not market it. Even this company which is actually sponsoring our, like the Zoom, they had this and then they never talk about it. We have to pull it out of their mouth sometimes, is there? Yes, sir, it is there, but not there kind of things, So it is a very good molecule. And I think we shouldn't be really, dismissing it. That's a great question. I think not much has been done. It's very sorry state of affair. I think we are also too worried and too preoccupied with the side effects. The 2-3 individuals that I have given, they love the drug because they've shown a lot of improvement. But the only trouble with MOA inhibitors is the switch mania in the so-called bipolar depression is very, very quick. So you have to be very careful in ruling out bipolar depression. That's my only caution, not anything else. I don't really worry about the adverse reaction. I make a diagnosis. I know for sure it is not a bipolar depression. I'm happy to give MOA inhibitor.
But I don't know about phenylcyprine, but definitely moclobamide was available in India.
Still available. Theoretically still available, but I think relevance is a better drug than moclobamide. People get it through internet, sir. You will be surprised. It is delivered to the house. After all, it's not a scheduled drug. People get it through the internet. My patients who have been on relevance, they actually have a better effect than moclobamide. They didn't tolerate moclobamide, but this drug was very effective. I was wondering why people would not market this compared to moclobamide. Even the research indicates that that is a superior drug. But I know for whatever reasons, companies have not taken it up.
Sir, we will try to make your answer short because there are too many questions.
Oh, sorry.
Most of the questions are directed.
You can pick the questions.
1 minute, sir.
Sir, you can restrict. Sir, we can restrict to another 2 or 3 questions.
Yeah, exactly, sir. Your choice, sir.
3 questions. 3 questions,
Yes.
sir. Very relevant questions I will ask you. Do you advise using 3 antidepressants with different mechanisms in treatment-resistant depression? That's what you had been talking about.
Yes, sir. No evidence. No evidence. Practice, very common. No evidence.
Then the question probably Dr. Raman will be able to answer because you are constantly answering most of the questions because it's related to glutamate.
Please.
Glutamate role in depression as compared with schizophrenia. This question is from Dr. Lalita of Visakhapatnam.
Yeah. So glutamate dysfunction in schizophrenia is a well-established entity. So, but like glutamate role in depression is like how we are looking at like emerging field. So that's why the focus of like it all started after ketamine was discovered. So like otherwise like the glutamate would not have been actually talked about in this much intensity with regard to research in like major depressive disorder. So major thing like started with regard to only ketamine. And then like definitely there are new targets which are being investigated. So one of them is rapastinel, which is another drug which is, although like many RCTs doesn't talk about efficacy. So that's also a glycine modulator drug. So it's a partial agonist like D-cycloserine. So there is a lot of research, like as I pointed out, great research on glutamate. So there is a literature review on in 2020 in drug. I just wanted to smell the expert opinion on therapeutic drugs in 2020. That's a very good, interesting literature review. It's expert opinion on therapeutic drugs 2020. All the RCTs related to glutamate-related modulation in major depressive disorder and the therapeutic targets.
Okay, sir. I think I'm clubbing next 3 questions together because they're all related to role of ketamine in treatment-resistant depression. I don't know who can answer this.
Raman should answer.
Role of ketamine in treatment.
He's the expert on it.
Yes, sir. There are a lot of RCTs like in of ketamine in treatment-resistant depression. So what has been proven is like 0.5 to ketamine in with 0.5 to 1 milligram per kg. That's the dose like advocated, and the response has been documented like as early as 40 minutes. So the only thing is like how long can we use ketamine is a big question. So like because the studies are focused on like maintenance of ketamine efficacy for at least 4 weeks. So after that, like I think like it's an individual preference, but there have been a survey in US among all the psychiatrists very recently on how frequently maintenance dose of ketamine is being done. Many people have responded to maintaining for twice a week at least. Twice a week, but most of the studies have combined with oral antidepressants. So it's not that like ketamine is alone have to be used. You'll have to combine with the oral antidepressants. Esketamine intranasal spray, there are few like trials which have come up. The doses that are being used is like 56 milligram and 84 milligram. So they have recommended for how to use esketamine in MDD for induction. So what they say is like you will have to use 84 milligram for 4 weeks, first 4 weeks, like on twice weekly. After that, you can reduce it to 56 milligram once a week. So that's the maintenance dose like that they recommend for esketamine intranasal spray. With regard to tyneptine, sir, like definitely tyneptine was originally marketed with a big market with regard to focus on synaptic plasticity. One of the major therapeutic target for tyneptine was like synaptic plasticity. So definitely when synaptic plasticity and BDNF is touched upon without glutamate modulation, it cannot happen. So, but I did not know why tyneptine lost its efficacy. So that point I'm not able to understand. So, but definitely glutamate modulation has been one of the major mechanism of action for tyneptine as well.
Thank you very much, Dr. Raman. I think I will restrict to 2 interesting questions because other things are routine. One question is from Dr. Namrata Charles from Udupi. She asked whether there is anything in the classification called as treatment resistant.
So it's a there is no consensus on treatment resistant. As you rightly said, if you go through
what I told in the
research articles, 10 research articles, they have defined it. The one that I came up with, the one which has been most quoted, doesn't mean that everybody has agreed on it. 2 trials with 2 different classes with optimal dose and duration is what many people have considered. Most people are confusing with non-response and treatment resistance. That's also another problem. So it's not a really defined concept. Even though there is so much of literature on treatment resistant depression, there is no consensus in the definition.
Okay, sir. Then we will move over to the last question. That is the clinical predictors of future treatment resistant depression. In future of treatment resistant depression.
Yeah, the future is very simple at this point in time. Clinical features are, you know, like really elderly people, people with comorbidities, at times severity of depression. That's controversial. Severity of depression, yes and no. Fourthly, people with certain genes which interfere with the tryptophan metabolism. And lastly, poor adherent people. And this
probably I will, with your permission, I will add one more, sir,
yes,
which
sir.
you have not dealt with in detail as such. Probably have not even mentioned it. That is probably pharmacogenomics.
Yes, yes, absolutely right. Right. It's, I think by mistake, it's got off my, it's there in the slide, in the original slide. The pharmacogenomics is very important. And lastly, I think we will be able to do that with the biological biomarker. Biomarkers will actually be able to help us to predict. That's where things will change.
Thank you very much. Both
Esketamine be available?
Dr. Shanti, please.
Shanti?
When will intranasal esketamine be available for use in India, sir?
That's $1 million question because, you know, even ketamine is not actually approved by the regulatory agencies. You're all giving it off the label, you know, thing. You know, most of the people are giving it off label only at the moment. It's not regulated at the moment because ketamine is a little, you know, it's still a scheduled drug, no? So I think procuring and stocking, all this is a problem. You can't. NASA international, you know, nasal spray will make the thing different. But I think with the patency period will take a lot more years for it to become available in India.
Not only that, sir, even if esketamine is approved, it will be still probably a scheduled drug because I think it has got a abuse potential.
Yes, yes, yes.
You can't deny that.
Of course.
Anyway, sir, thank you very much for making this evening very pleasant with very, very constructive deliberations on 2 important topics related to depression. One is glutamate, the other one is treatment resistance. Thank you very much, both of you, Professor Raman and Professor Suresh Kumar.
Thank you so much,
It's a
sir.
real nice chance for me to be with you on this particular session. And I should thank on your behalf also the organizing committee of the CME of Southzone, as well as the president and other office bearers of Southzone. Thank you very much, Dr. Ramakrishnan sir, especially.
Thank you, sir.
Dr. Lokesh, I just want you to come to deliver the vote of thanks, Lokesh.
A very warm good evening to everyone. On behalf of the CME committee, IPS South Zonal Branch, I am happy to propose the vote of thanks. At the outset, I thank the speakers, Dr. M. Suresh Kumar sir and Dr. K. Raman Garu, for readily accepting our invitation to be the speakers for this monthly second WISER CME. Thank you very much, sir, for the wonderful lecture on the clinically useful topics. I also extend our heartfelt thanks to Dr. T.P. Sudhakar sir for accepting to be the chairperson for this CME in spite of his busy schedule. I thank our president, Dr. Ramakrishnan sir, for his constant monitoring and motivation to make this CME a successful one. I extend my thanks to the chairman, CME committee, Dr. V.K. Arvind sir, for choosing good topics and eminent speakers and showing the way forward for the upcoming CMEs. I thank all the office bearers and EC members for their support. I thank all the esteemed members for their active participation to make this CME a grand success. I also extend my thanks to other CME committee members for their contribution. We extend our thanks to Sun Pharma for their technical support to this CME. And I wish to inform that all the delegates who have registered will be receiving an e-certificate through your mail from Sun Pharma representative. Thank you and good night.
Before I just close the session, I just want to make a small announcement from the CME South Zone Committee. So next monthly meeting will be decided depending upon the ANSIPs, and we have already chosen one speaker for next topic. I mean, next CME session is one Dr. Padmavati Madam will be speaking from staff director, will be talking about something related about the comorbidity of schizophrenia, and Professor Prabha Chandra will be chairing the session. And I'm just picking one more young psychiatrist to talk on the same platform on schizophrenia. So this is just one information to conclude. Thank you very much and good night.
Thank you so much, sir. Thank you.
Thank you. Thank you.
Thank you, Dr. Raman. Thank you. Thank you, sir.
Thank you, sir. Thank you. Thank you.
Thank you, Dr.
Thank you, sir.
Sir, Sudhakar Garu, thank you. Thank you, all people. Good night.
Thank you, sir. Good night, sir.
Good night, sir.